Hi, my name is Amber Ricketts, and today for my capstone presentation, I will be discussing the effects of melatonin on patients with ICU delirium. As we all probably know, sleep is an important part of healing. Sleep has been found to engage the brain in activities that are necessary to life and directly linked to quality of life. There are two different types of sleep, REM and non-REM sleep, that make up your sleep cycle. Your sleep cycle is based on circadian rhythms, which is basically your brain's biological clock, which sends signals as the sun goes down to increase production of melatonin and get you ready for bed, and as the sun rises, the melatonin is reduced to wake you up for the day. Without these signals, the brain is not able to release melatonin effectively. Without sleep, the brain loses the ability to hold on to information, also known as brain plasticity, and causes us to forget things. Sleep also affects blood pressure, migraine and seizure prevalence, increases the risk for depression, and depletes our immunity, making us more prone to infection. In this graphic, as you can see, at about 9 o'clock p.m., melatonin secretion starts, getting us ready for bed, as I previously stated. As you make your way around the clock to 7:30 a.m., melatonin secretion stops and wakes us up for the day. Intensive care unit delirium, also known as ICU delirium, is an acute brain dysfunction that has been associated with increased mortality, prolonged ICU and hospital lengths of stay, and development of post-ICU cognitive impairment. Delirium is reported in 11 to up to 87% of ICU patients. My PICO question that I will be discussing is, in ICU patients, does the administration of prophylactic melatonin decrease the rate of delirium when compared to no intervention for ICU delirium? The first literature article that I found was a journal article written by Baumgartner. It was shown that the effects of melatonin decreased the prevalence of ICU delirium by 16.6% in this journal article. Specifically, there were 232 adults in the study from medical surgical ICU data from 2013 to 2017. There were 117 of these patients in the test group and received melatonin. The control group consisted of 115 patients and had to be admitted to the ICU for 4 consecutive days without receiving melatonin or antipsychotics within the first 4 days of their stay. Only 9 people in the experimental group developed ICU delirium compared to 28 patients in the control group. And the second piece of literature I found was a systematic review of a meta-analysis of randomized controlled trials. The theory that prophylactic use of melatonin would decrease the rate of ICU delirium is supported in this systematic review. 8 random controlled trials were included in the analysis. 182 records were used for the quantitative analysis, consisting of 409 total participants. 201 subjects were placed in the experimental group and 208 to the control group. Results in this review showed a prevalence of 3 to 50.85% delirium in the experimental group, compared to 32 to 84.1% of delirium in the control group. That's almost twice as much prevalence in the control group as compared to the experimental group. The third piece of literature that I found was a randomized control study. The question of if prophylactic melatonin would decrease ICU delirium is also supported in this study. There were 210 patients who completed the protocol. The study focused on the amount of melatonin that was given related to the prevalence of delirium. It was found in this study that 3 milligrams of melatonin had the best results and ultimately decreased delirium in the ICU. For the biomedical humanities portion of this presentation, I focused on interprofessional perspectives. Specifically, I found perspectives of pharmacists and their feelings about if patients should be medicated for sleep. 195 pharmacists completed a survey based on the use of pharmacological methods to promote sleep in ICU patients. 81% of participants recommended non-pharmacological methods in addition to pharmacological methods, while 91% only recommended pharmacological methods alone. 41% recommended adjusting medications to optimize sleep, while 33% specifically recommended using melatonin. A solution or recommendations that I have for this research was, it was found that there is limited data on whether prophylactic melatonin will decrease delirium in ICU patients. While much of the research that I found supported this question, there was also research that showed data where melatonin was not helpful in decreasing ICU delirium. However, the use of melatonin was never shown to cause or increase the prevalence of ICU delirium or cause any additional harm to the patient in the research that I found. With more research, I believe there can and will be more concrete data supporting the prophylactic use of melatonin for ICU patients. Reflecting on this research, researching the topic did not change my perspective, but it did, however, increase my knowledge and broaden my understanding for melatonin and the importance of sleep for our patients in delirium. I believe that promoting proper circadian rhythms and increasing sleep can better the overall health of our patients, and using a drug such as melatonin, which already resides within the human body, is the best and most ethical way to start. To close out this presentation, I wanted to show a graphic of common sleep deprivation symptoms. As you can see, these symptoms are similar, if not synonymous, to the symptoms of delirium. Thank you.